This is a presentation on diabetic macular edema and especially focused on the anti-VEGF therapy for diabetic macular edema. Incidentally, this is also a presentation which I had presented in one of the local CMEs at Pryagraj, organized by Allahabad Ophthalmic Society. Now, macular edema is the commonest cause of diminution of vision in diabetic patients who have diabetic retinopathy. Assessing diabetic maculopathy or diabetic macular edema requires clinical examination, which is the most straightforward method. So on fundus evaluation, one can appreciate thickening of retina at the fovea or around that area, presence of hard exudates, and one can easily appreciate absence of foveal reflex in these retina which get thick and the foveal reflex is obliterated. Another method is fluorescein angiography, which can very categorically diagnose macular edema, and this is one representative late phase angiogram photograph which shows presence of flower petal appearance which is seen in the late phase of these patients who have cystoid macular edema. Finally, the tool which is most commonly used presently is optical coherence tomography, and this not only gives you presence or absence of macular edema, it also tells you about the thickness of the retina using a cross section of the retina at a desired spot. It provides you the visualization of cystic spaces in the retina, presence or absence of subretinal fluid, the structure and anatomy of the outer retinal layers, the inner retinal layers, presence of any vitreomacular traction, and presence of any reflective foci which can be a sign of degenerative change and also seen in situations when you have exudative plaque. However, OCT fails to provide information about capillary non-perfusion, which may be an associated feature in these patients. So one has to actually learn to look at OCT so as to not only diagnose the macular edema but also identify features which are important in the management and counseling the prognosis of the disease when the treatment is initiated. So foveal thickness standing for T, the size of intraretinal cysts, the external limiting membrane or ellipsoid zone which is depicted here as E. Then you have drill, it's a term which means disorganization of the retinal inner layers, and here we have put that as D. Hyperreflective foci H, subretinal fluid F, VMT is V. Now I have also devised a mnemonic so as to easily remember this list, and this goes like thick crows eating dangerous hot sauce vigorously. It was a very random thought in my mind, so it is not a very popular phrase, but if one can mug it up, you can actually recall all possible situations which are important for assessment of macular edema. So coming to each of these features, T for thickness. So in this photograph we can see this is a OCT which shows as a cross section, and this is the area where there is edema, and we can manage and also see a ETDRS 9 sector projection over this area which has been translated in objectively measuring the macular or retinal thickness and depicted here in each of the sectors. And so this is central subfield thickness or CST, and if this goes more than 300, so we can see this is something like 250 to 225, and this is how it is depicted in a normal photograph or a normal patient. And the moment we look at this, we will find that any CMT, central macular thickness or subfoveal thickness, which is more than 300 microns, is definitely pathological. Another feature which we should look at is presence of cysts. Now these cysts can be seen in various forms, and here we have two examples where we can see that not only this retina is thickened, there are clear cystic spaces which are multiple. In addition, we can have a situation where you have a single cyst, large cyst, which is surrounded by smaller cysts. So it can be this situation or this situation, but overall they represent presence of cyst in the retina, which is edematous. Disruption of outer retinal layers. So here we can see in this photograph, I have also shared with you a normal looking OCT, and look at this point which shows the ellipsoid zone and the external limiting membrane, which is the fourth hyperreflective band on our OCT. And if we look at this point, we'll find that this corresponds to this line, which is definitely disrupted in this area. So this is something which is representing the outer retinal layer, and you can have disruption of ellipsoid zone, that is the inner segment outer segment connection zone, and the external limiting membrane, and these are important parameters which will predict the prognosis. You can have drill, so outer retinal layer can get disorganized, but also the inner retinal layers. And this is one very good photograph of a OCT, but this is not a diabetic retinopathy patient, it is a retinal vein occlusion patient, so branch retinal vein occlusion, and this is the only situation where you can have half of the retina which is grossly affected and other half is nearly normal. So point which has to be noted down here is that these are the inner retinal layers, and the white layers are basically the plexiform layers, and the dark bands are the nuclear layers. So we can see that we can make out each of these layers separately: the outer nuclear, the outer plexiform, inner nuclear, inner plexiform, the ganglion cell layer, and the nerve fiber layer. But when it comes to the right hand side, we can see this is the side which has been affected by the branch retinal vein occlusion, and this is the left eye. As we can appreciate the thicker nerve fiber layer on this side, so this is the nasal side, and this is the temporal side. And now we can appreciate that this differentiation of these segments of the cross section on a retina are missing here, and we can't see and make out any of the layers here, and this is what is known as DRIL, disorganization of retinal inner layers. Presence of hyperreflective foci. So this is a photograph of the same patient where we can see this patch of hard exudate, which is seen here on our OCT as a hyperreflective foci. So this can actually be a situation like this, and also there can be hyperreflective foci which are seen in the deeper layers, but they are smaller and they are not visible on normal fundus photographs. So they are also a parameter which predict a poorer prognosis and poor response to visual gain after resolution of macular edema. Presence or absence of subretinal fluid is again a finding which should be noted well on a OCT. And here we have one OCT where we can see the retina is thickened, the foveal reflex which should have been here is obliterated, you can have cysts, and there is separation of neurosensory retina from retinal pigment epithelium and presence of a clear cystic space, and this is subretinal fluid. The diabetic maculopathy can be classified based on OCT images, and this is not within the scope of this particular talk, but I'll just introduce that usually these classification system give you a score based on these parameters which I have discussed above, and then you can have a score which has been categorized and stratified into early diabetic maculopathy, advanced, severe, and atrophic maculopathy. And presently there is a lot of work which is going on, automated or artificial intelligence based classification of diabetic maculopathy. So in coming time we'll have situation where you simply give the OCT to a machine, it will read it out and give you a score, and that will be easy process for standard operating procedure for deciding the management plan. Now coming to the treatment option or treatment of diabetic macular edema. So here I have given you the left side, these are the therapies for the local intervention, and on the right side you have the major or the systemic management of situation. And it's very important to understand that metabolic control is the key factor when it comes to managing any complication of diabetes. So blood sugar has to be very carefully and strictly monitored and controlled. Apart from that, we have to look at the renal functions, and if there is nephropathy, one has to be very vigilant and take opinion from nephrologist, because a deranged renal function is going to cause worsening of maculopathy. Once these patients start having nephropathy, as we all know, the hematopoietic factor is produced by the kidneys, and a deranged kidney function and deranged kidney cannot produce this hematopoietic factor, and these patients invariably go into anemia, and this anemia worsens the maculopathy because it increases the hypoxia. Then there are vitamins, and vitamin D3 or cholecalciferol is being studied and is widely reported now as one of the factors which can cause worsening and contribute to the worsening of diabetic maculopathy. Here we'll talk about the local therapies, and out of these treatment options we have laser, anti-VEGF and steroids. And during the present time, anti-VEGF is the mainstay of treatment for these patients because it can cause improvement in vision with least of side effects. So for these choice of anti-VEGF, we have these molecules available. However, I will restrict my talk to bevacizumab, which is something which I used most commonly. Rather, I use exclusively bevacizumab, and I have very good experience with this molecule, which is presently labeled as off-label use in ophthalmology. And this also is a nothing less than a conspiracy by bigger pharmaceutical company, but for which there's another talk. So this is, I'm just limiting myself to the utility of bevacizumab in these patients. So when to treat these patients using anti-VEGF? So when we have to understand that there's a sort of spectrum here, and this is a continuous spectrum where on one hand we have patients who do not need injection like this because metabolic control and the disease mildness plus tendency for them to improve with minimal medications is high. So don't go for injecting anti-VEGF for these patients, and the characteristics are that there is a non-center involving diabetic macular edema. The vision is usually very good, 6/6, 6/9, 6/12 or so, and this number of cysts is very small and the cysts are small. On the other hand, we have these patients in whom there is no benefit whatever you do, and these are the patients who have exudative plaque at macula which is close to fovea or right at the fovea. Then you have patients who have disorganized inner retinal layers, and these patients, even if the macular edema resolves, the visual gain is minimum. So the point is that you may treat them, but be very cautious and counsel them that the visual gain may not be as much as they expect. And in middle we have these patients who will definitely have improvement with anti-VEGF, and these are the patients who have non-center involving macular edema, which is CSME by definition as per the ETDRS guidelines, which says that any area of 1 disc diameter which is within 500 microns of the foveal area is something which can cause a diminution of vision in upcoming 1 year. Then you have treatment naive center involving diabetic macular edema, vision less than 6/12, and frank cystoid macular edema. These patients deserve this treatment and they will benefit and have good response when you inject anti-VEGF as an intravitreal injection in these patients. So looking at this, was one of my patient who was presented to me with this kind of picture, and this patient was not injected any medication, and 2 months after strict control and metabolic correction of the deranged parameters plus topical NSAID, that is bromfenac eye drop, and a difluprednate, that is a topical steroid eye drop, the situation shifted from this particular view to this picture, which is nearly normal. The foveal thickness has come out to be nearly normal. There are remaining 2 cysts and the vision had improved dramatically. So these are the patients who, if inspired and they are under good metabolic control, will do well without injection. So one has to identify them. However, there remains one caveat here, that this is the posterior vitreous phase, which seems to be attached to this point, and there may be some element of VMT which has spontaneously resolved here, and this also may be a reason why he improved. But still, the point is that there is a spectrum of patients who don't need this aggressive injection. Those patients who will not benefit from injecting anti-VEGF, one of them is like this picture, where you have a dense thick plaque of lipid and lipoproteins right at the macula involving fovea, and these patients have exudative maculopathy, and these patients, even if the OCT picture may improve, the retinal thickness may improve, but when you find that the improvement is there, the thickness is reduced, but still these patients don't get central vision. And here also we can appreciate that there is some amount of VMT which has got detached here. So it is also known that all these injections and any disturbance which you create in the vitreous and vitreous is traumatized, ultimately this will result into a PVD, and which is a welcome sign in these patients, because PVD will prevent so many further events which can cause and contribute to further diminution of vision. Patients who have optic atrophy will usually not benefit from injecting anti-VEGF, and here we can see a patient in whom we have a venous block in this area, and the disc is very pale, and these patients are also having retinopathy in association with various arterial and venous blocks, and this patient has gone into a proliferative phase with this bleed, and we can appreciate the disc is pale, and this can also happen with patients who have had extensive panretinal photocoagulation, and if the retina gets atrophic, the optic atrophy ensues, and these patients will again not respond to anti-VEGF. Then finally, patients who have disorganization of retinal inner layers, and this is one good photograph comparing a drill patient with no drill. So this is taken from Kerala Journal of Ophthalmology, and this shows you the OCT image, which shows very nice segregation of all the retinal layers, in contrast to a patient with drill where there is amorphous tissue and these 2 cysts, and you cannot differentiate the individual layers in this OCT. So this patient will not benefit from any anti-VEGF therapy, so one has to be very cautious in counseling these patients. Coming to how I treat my patients, so these patients are subjected to these baseline investigations when the plan to inject anti-VEGF is made out. So we have glycosylated hemoglobin, a hemogram, kidney function test, blood pressure, OCT, macular fundus photo, and blood sugars. And out of these, each one of them has an importance, because glycosylated hemoglobin gives you a very exact and very I would say the idea about chronic control of blood sugar, which is so very important. Hemogram and KFT will tell you about ongoing hypoxia process because of low hemoglobin, and kidney function test, which is actually contributing to anemia, control of blood pressure, and OCT, macula and fundus photo to document, and last is the blood sugar, which is more or less for documenting that the sugar at the time of injection was within control. So preparation is just like any intraocular surgery. So don't take these injections casually. Injecting these injections in OPD or in a clean room is not sufficient. So it should be operating room setup, and just like you operate your cataracts, use betadine, drape, aseptic injection technique should be used, and patient. This short video is about how to deliver a painless intravitreal injection. Now the key factor here is to do a paracentesis so as to compensate for whatever volume we are injecting. And the post-injection pain is mostly due to the raised IOP, which settles down in an hour or so as proven by several studies. So you remove the same amount of aqueous equal to the amount which you are planning to inject, and this will not allow intraocular pressure to increase. The rest of it is same whether you use topical application of eye drop or jelly. So if you keep this in mind, the pain will be least. And for paracentesis, it is important that pupil should not be dilated. Thank you. So this was a short clip which depicts how intravitreal injection should be given. Apart from the technique, what I wanted to emphasize was a pre-injection paracentesis so as to equalize the pressure. When you inject anti-VEGF, there is no volume change and the pressure remains within normal limit, which is very important because these patients will experience some amount of pain, discomfort and headache which will persist for something like half an hour to 1 hour, and that is very easily avoidable if IOP is controlled either by this paracentesis of giving these patients some amount of astazolamide before injecting this. Post-op or post-injection care and visits. Day 1 is a safety visit to see that everything is within control, and follow-up visits are scheduled at day 7, day 30 to 40 when the OCT macula is done, so as to judge what is the change in the disease, and at the same time visual acuity is measured. And topical medications are given in form of antibiotic eye drop for 5 days, and topical NSAID eye drop and topical steroids are continued as before, and also an oral antioxidant tablet is given to these patients. And during this phase, the patient is encouraged to strictly monitor and regulate the blood sugars. So once you have treated these patients, because this is a disease which may require continuous follow-up and maybe multiple injections, so one has to decide how much to treat. So we stop anti-VEGF therapy when you think that the retinal contour has come back to normal and vision has improved. So normal foveal contour, reduction in retinal thickening at macula, regression of the SRF and disappearance of cystic spaces in the neurosensory retina, as we can see in this case, what has happened at 4 weeks. But apart from that, you can have a situation where though there is improvement, as you can see on this photograph, the improvement is there, the retinal edema area has reduced, the thickness has reduced, but still it is not normal. So these patients will need repeat injections, maybe at 4 weeks, maybe at 6 weeks, but these will need repeat injections, and again this is an important issue which should be very well discussed when starting the treatment. Now what happens to these patients if they don't respond? Then one has to shift to and consider laser into the picture, which will cut off the production of VEGF which is occurring at the ischemic areas in the retina, and that it may help in resolving these patients. One should also look at VMT, and any amount of surface traction will not relieve the retina from its edema. So in that situation, surgical removal of epiretinal membrane should be considered. There is another option for these patients, that is steroids. Now you can switch to intravitreal steroids, keeping in mind that there may be a IOP rise, and that is why the steroids are the second choice, but they are useful. So when the patient has difficult follow-up and steroids depot preparation like Ozurdex and specifically triamcinolone, which I use preferably over as Ozurdex, has a long intraocular life, so it can work for these patients for more than 4 months. So it can be used in patients who are at poor compliance, poor follow-up, pseudophakic patients who have reached a plateau, and persistent edema who need cataract surgery, and patients in whom the anti-VEGF is contraindicated at a point because of a vascular occlusion event somewhere else, maybe in heart, maybe in brain, and when there is presence of exudative heart, extensive heart exudates and hyperreflective dots on OCT. But at the bottom line is that one has to keep an eye on the intraocular pressure, because these patients may also have glaucoma, not only pre-existing glaucoma, but can occur because of these steroids. So one has to be vigilant about it, and at the point of decision to inject this medication, one has to also counsel the patient the possibility of glaucoma. So this is all about what anti-VEGF are useful in diabetic macular edema, and this is one example patient who at May 2016 versus March 2022, he has maintained very steady improvement and has a absolutely dry retina now with visual acuity which is very good, that is 612 BCVA, and this is how you can treat and manage these patients using anti-VEGF. Thank you.